Morning, everyone. Presenting behalf of Medicine 4. Mrs. X, a 29-year-old lady from West Bengal, housewife, presented with the complaints of fever on and off for 8 years, right upper abdominal pain on and off for 8 years, and loss of weight and loss of appetite. History of presenting illness: she was apparently well until 8 years ago. Then she developed fever, which was intermittent, high grade, associated with chills and rigors. The fever was on and off, usually comes in once in a month or two, with each fever spike lasts for 36 to 48 hours. Recently, her fever frequency increased to once or twice a week, with each fever spike lasted for 3 to 4 days for the past 6 months. Highest temperature documented were 104 degrees Fahrenheit. She has received injection amikacin stat dose for each fever spike for the past 6 months in a nearby clinic. The fever was associated with generalized myalgia. The fever was associated with the right upper abdominal pain, usually colicky type of pain, increases in severity during fever. Pain is not aggravated with food intake, not associated with the nausea, vomiting, or loose stools or constipation. She also has noticed weight loss of around 20 kilograms for the past 8 years, with around 4 kilograms over the past 6 months. She also has a recent onset loss of appetite. Past history wise, nil comorbidities. She had no history of contact with tuberculosis. She underwent cholecystectomy in 2022 in view of acute calculus cholecystitis. She was told to have a biochemical jaundice that was resolved post surgery. Family history: her uncle was diagnosed with DCLD at the age of 52 that was not evaluated. He was not diabetic, he was not alcoholic. Obstetric history: she has two induced abortion. Vitals at presentation were temperature were 104 degrees Celsius for Fahrenheit, sorry. Pulse were 110 per minute. BP were normal, SpO2 were normal. She was conscious for the time and to time, place, and person. There was pallor was there. No ictus, no cyanosis, no clubbing, no pedal edema. Systemic examination: abdomen was soft. Right hypochondrial tenderness was there. Liver was palpable 1 centimeter below the right costal margin. Spleen were palpable 2 centimeter below the left costal margin. While CVS and RS examinations were normal. Summarizing, 29-year-old female presented with the complaints of on and off high-grade fever for 8 years, significant weight loss, and right hypochondrial pain and tenderness. With clinical examination revealed pallor and hepatosplenomegaly. So we worked her up as a PUO since it includes autoimmune disorders like SLE, rheumatoid, Sjogren's, while infectious like chronic malaria, tuberculosis, brucellosis, leishmania, while hematological disorders, lymphoma, leukemias, myeloproliferative disorders, myelodysplastic syndromes. Initial investigation showed counts were 10,500, HB was 7.6, platelets were 5 lakhs with high ferritin, retics were 1.31 with iron deficiency there, like iron were 15 and TABC were 157, urea creat were normal, higher normal, LDH were 167, DCT were negative. While LFT showed elevated alkaline phosphatase and elevated GGT. While infective workup were negative, includes malaria, rabbit bloodborne virus, brucella, blood cultures, but bone marrow expert, bone marrow fungal, and RK13 antigens were negative. Bone marrow showed plasmacytosis with no light chain restriction, with kappa lambda ratio were normal. Electrophoresis showed diffuse increase in alpha 1, alpha 2, beta 2, and increase in gamma region, while urine BJP were negative. The calcium and phosphorus were in normal limit. Well, autoimmune workup were negative, includes CRP, and complements anti-TSGNA, anti-SSB, anti-SSB, and ANCAS were negative. Further evaluation with cross-sectional imaging showed dilated CBT along its course and bilateral central moderate IHBRD with cystic dilatation of biliary duct in segment 7 with enlarged periportal and peripancreatic nodes and hepatosplenomegaly were there. So MRCP showed few cystic dilatation of intrahepatic bile duct, again same in the right lobe with IHBRD with dilated CBD throughout with smooth tapering. Underlying ductal plate malformation, which is choledochal cyst type 4A. So again, EUS, since she had the CBD, smooth tapering of CBD, EUS was done. EUS showed smooth distal tapering with sludge in the distal CBD, while biopsy of the periportal peripancreatic were negative for TB and malignancy. So we came to the diagnosis of choledochal cyst, which is type 4A, causing recurrent cholangitis. So a few points on biliary cyst, which The incidence of biliary cysts in Western population are estimated to be 1 in 1 lakh population to 1 in 1 lakh 50,000 population, with more common in the female with a ratio of 3:1 to 4:1. The majority of cases reported in the children, while some series report as showed equal number in both adults and children. Well, it's mostly associated with the ADPKD and FAP, familial adenomatous polyposis. These are the types of biliary cysts. Includes type 1 is fusiform dilation of CBD. Type 2 is diverticulum. Type 3 is choledochal cyst. Type 4 is intra and extrahepatic cyst. Type 4B is extrahepatic cyst. Type 5 is, as we all know, the Caroli's disease. Type 6 is cystic dilation of cystic duct. While type 1 is more common in the children, while type 4A is more common in the adults. This is a retrospective study done in a tertiary care center in the Kashmir, showing the same. Type 4A is typically seen in the adult group, usually present as ascending cholangitis, recurrent cholangitis, anatomical strictures, choledocholithiasis, and cholangiocarcinoma in 10 to 30% of the people with type 4A. Usually, the classical triad of biliary cyst includes abdominal pain, jaundice, and palpable mass. It usually presents at 12 to 20% of the people. However, most people usually will have one or two element of this triad, usually either abdominal pain or jaundice or palpable mass, not all the three. So atypical presentation usually includes nausea, vomiting, fever, pruritus, and weight loss. The complication of which includes choledocholithiasis, recurrent cholangitis, ductal strictures, pancreatitis, recurrent pancreatitis, secondary biliary cirrhosis, and cholangiocarcinomas. A few points on cholangitis. As we all know, cholangitis usually present as a Charcot's triad, which includes fever, abdominal pain, and jaundice, but not on all the case. Like only 50 to 75% of the people will have this classical triad of Charcot's. While fever and abdominal pain presentation usually it will be present as a fever and abdominal pain 80% of the people, while usually present as a jaundice in 60 to 70% of the people. While severe suppurative cholangitis will present as a Charcot's plus hypotension plus altered mental status, which is Raynaud's painter. Diagnosis of cholangitis usually includes one of the following, which includes fever with chills and or elevated counts with elevated CRPs, and both of the following, which includes evidence of cholestasis and imaging with biliary dilatation with underlying etiology like strictures, stones, and stents. Management usually surgical management. With type 1, type 2, type 4 should undergo surgical resection of the cyst in view of high risk for malignancy. Type 3 should undergo sphincterotomy and endoscopic resection, as type 3 has a good prognosis. Type 4, as we all know, it includes both intrahepatic cysts. They should undergo liver transplantation. Is a worst prognosis among all. Our case, hepatology was involved. She was started on a cyclical antibiotic till surgical intervention. HPB also was involved. She was planned for ERCP and stunting and surgical excision of cyst in view of type 4A, as it has 10 to 30% of the risk of having cholangiocarcinomas in very future. Yeah. The learning points includes biliary cyst should be considered a patient presenting with a recurrent fever and right hypochondrial pain, and yearly identification intervention prevents complication like malignancy, include cholangiocarcinoma. Thank you.
Okay, thank you. Give him a hand. Did she have fever while she was admitted with you?
Yes.
Do you have any picture of that?
Fever.
Yeah, the pattern. Just go to your.
No, I don't have currently.
Yeah, just go to your first slide. No, describing her fever. So she would have fever for a few days. Is it every month?
Yes, ma'am.
Continuous fever.
Lasted for 36 to 48 hours.
Okay, and would it respond to the antibiotic that
Usually respond. Usually, she used to get antibiotics in a local clinic, ma'am. Whenever she gets a fever, that was not evaluated. She used to get antibiotics and just amikacin usually.
And then 2 years ago, she had a acute calculus cholecystitis, or was it a
That
similar
wasn't
episode?
documented, as she says, ma'am. I said no documentation of calculus cholecystitis.
Okay.
She says she has this stone. That's why she was.
Okay, and for how long from when has this worsened, this fever?
For the past 6 months.
Okay, so in a person who has had a cholecystitis, who's come like this, what is another differential you should consider?
Choledocholithiasis. or a biliary stricture can be one possible.
Okay. Sometimes they can even have a dropped stone, which can be a
Yeah.
focus, a nidus, and cause recurrent infections. Just go to your list of differentials. Or before that, just your clinical examination, right? So you said there was right hypochondrial tenderness. So and the liver was also palpable. So are you saying that the liver was tender?
Yes, ma'am.
Okay. Now just go to your list of diagnosis. So yeah, before this, so you have a patient who has these recurrent episodes of fever, and you have clinical findings of a tender hepatomegaly, right? So good. So in that, how will you, list out your order of diagnosis? The
One
first will
is
not be SLE in this case, no? So you need to order these diagnosis based on the presentation your patient has.
yeah.
Okay. Um, you have not put cholangitis here, right?
Yeah, we weren't thinking of. Yeah, ma'am.
You are not thinking of it. So we have to be clinical,
Yeah.
right? Yeah. Please go. Why does the patient have splenomegaly?
Uh, Maybe as a part of chronic inflammation, ma'am.
Did imaging
Notes were there.
confirm that there
Yeah,
was
yeah.
splenomegaly?
Splenomegaly was there. Yeah.
Okay, because
No,
you don't
multiple
expect,
notes were
no?
there.
Mm,
Multiple peripartal, peripancreatic node were there, along
okay.
with splenomegaly was there. Madam, part of chronic inflammation. She was.
Okay,
She
one other
has this.
differential you should have considered also infective endocarditis if you were thinking of
Yes,
episodes
ma'am.
like this, right? Okay.
Echo was done. It was normal.
So your blood cultures
Yeah,
did they
negative.
show
Nothing.
anything?
No, ma'am.
No. Did
No.
you send the bile for culture?
Sorry.
When they did the procedure, did they send the bile for culture?
Yes, ma'am.
Did that grow anything?
Nothing. No, ma'am.
No.
No.
Okay. So I think we have to be a little more, clinical in our diagnosis. Okay. Yeah. Anybody?
Shows an elevated alkaline phosphatase, the chance that there is some obstruction or something in the liver, infiltrating the liver, is really high. Therefore, your next investigation just needs to be an ultrasound. That itself could have picked up probably the uh, dilated biliary radicals. And the other thing is the difference between a continuous fever and a fever that's episodic in that way. Actually, the differentials are completely different. You're not going to have a TB causing fever a few days, a month, so both the initial clinical evaluation is also different, as Kripa anyway already said. And even when you do the investigations, it's not that you just come up with a list of differentials and then you evaluate all of them at the same time. You evaluate the first few with the simplest investigations, and then if those are not yielding something, then you can go on to other investigations. So probably an ultrasound may have picked up the same diagnosis minus a bone marrow and minus a CT as well.
Yes, Amit.
I just wanted to, I'm curious to know if the surgery has been performed and if the carcinoma has yet been diagnosed or not. I don't know. No, the significant weight loss.
Yeah.
You think that's also chronic inflammation or
Can be.
just going to undergo the surgery? Isn't
Yeah,
it? Not yet.
not yet.
Curious to know about the biopsy.
Sir?
Okay. Thank you. We next have Tangamani from Medicine 5 presenting obscure.